Good afternoon. My name is Michael Diachenko, and I work with Optimus Technologies. Today, I'm going to be presenting a MIPS macro program overview. This is part one in a 5-part presentation series we're going to be publishing over the next few weeks that dives into the MIPS program. The other presentations you'll have available to you will be one focused on the test track, aka avoiding the penalty, and then deep dive into each of the 3 categories that quote unquote matter, and those being quality, advancing care information, and improvement activities. So that being said, today's is the program overview. So I'm going to start that shortly. The goal of this presentation is to introduce the program to you, touch on all of the concepts and kind of bring it full circle so you know what you have to do, and maybe what other those presentations you should attend. So like I said, today's presentation is going to be mostly an overview, so we'll start with terminology and program definitions. We'll then go over your reporting tracks that'll be unique to 2017, so this year, how payments work, so the payment adjustments, an overview of the category and scoring. So that'll kind of bring together at the end of the year what you're going to be looking at in terms of your MIPS performance, how to report, aka reporting options, some recommendations, and then references and resources. We'll also want to hold questions to the end, and I will address any that come up during the presentation. As for some common terminology, so we get questions about this quite a bit. MACRA stands for the Medicare Access and Chip Reauthorization Act of 2015. This is the legislation that introduced MIPS. So it's not the incentive program, it's the legislation that introduced MIPS, which is the incentive program. MIPS stands for the Merit-Based Incentive Payment System, and this is one of 2 tracks that MACRA introduced as their replacement for all previous incentive programs. This is the one that 98% of providers in the country will be doing, and basically everybody that would attend this call will be doing. If you're not part of MIPS and you're in an APM, you will know that. APM is the Advanced Alternate Payment Model. So that is the other incentive track. And like I said, it's very rare that anybody would be part of it right now. They have to be certified by CMS. But as the years progress, they're going to probably be pushing people towards this direction. And like I said, if you're in one or you will be in one, you will know. As far as some MIPS-specific terminology, there's MIPS categories. So these are the overarching pieces of the MIPS program, and they're familiar to you. It's quality, it's advancing care information. Those are the categories. And then MIPS measures are the things inside of those categories that you're actually attesting to or need to do. As far as an overview of the MIPS program, it's replacing all the existing Medicare incentive programs, so it's replacing meaningful use PQRS. It's comprised of 4 categories, all that have different weights this year and that will have different weights in the coming years. So they're going to be changing them as the years progress. Quality may become a bigger piece, it may become a smaller piece, and they'll adjust that based on performance. The big change from the previous iterations of the incentive program is that it's actually performance-based, so it's no longer just you hit a number and you pass. It's your performance rate on X measure equates to Y points, and that'll make sense as we move into the scoring piece and get into the individual categories in this presentation. Payment adjustments, so at the end of this whole thing, they're going to be based on they're going to be benchmarked against all participants in the country. So the idea here is to be budget neutral. So you won't actually know what your payment adjustment would be until after everybody's already submitted their data. CMS has processed it, so probably spring of 2018. In 2017, there are going to be multiple reporting tracks that will not be available to you in future years. So this is what they call their transition year. To be a MIPS eligible clinician, you have to hit both of the top 2 pieces. You have to see at least 100 Medicare patients and have billed at least $30,000 to those Medicare patients in one of those 2 periods of time. CMS calculates this based on claims, and if you meet the above, then you're in. One thing to note when we get to individual versus group reporting, if you report as a group, that's still your numbers. So if you have 10 providers and those 10 providers in aggregate see 100 patients and bill at least $30,000, your group could be MIPS eligible, well, the individuals inside of it that may only see 20 and bill 10,000 would not be eligible by themselves. And that'll make sense as we move into the group explanation. The website at the bottom of this slide is where you can go and look up your clinicians based on MPI number, and it'll tell you if they're MIPS eligible clinicians this year or not. It'll also let you know what organizations they may be a part of, so what TINs they roll up under, which would be important if you want to go the group path. The MIPS categories and weighting are as follows. So quality, which is basically formerly PQRS, is 60% of your MIPS score in 2017. Advancing care information, which is basically old meaningful use, is 25%. Improvement activities, which is new to MIPS, is 15% of your final score. And cost, which is formerly the value-based modifier, is going to be 0% weighted in 2017. It may have a weighting in 2018, but there's been some information coming out of CMS that they might push it back one more year with no weight. The only thing to know about cost, and we'll get to it when we get to that section real briefly, is it's calculated by CMS. So there's nothing you need to report or really do related to it. And there's going to be more information coming out about it in 2018, which is why it's 0 weighted this year. So your performance rates in each category are going to be totaled. That's your final MIPS score, and you're going to be scored out of 100 points. So 100's the best you can possibly do. And your score will roll up into some number under 100, and that'll make more sense as we go into scoring. One thing I like to note is CMS uses percentages and points as interchangeable terminology. I think it's easier to think of the whole program in points, so I'm going to try to stick with that throughout. So, like I said, 2017 is unique because it's the transition year, so it has some reporting tracks that will not be available in future years. 2 of them aren't really tracks, so I'll touch on each one of them individually, but if you do not participate, that's not really a reporting track. You're just not going to do MIPS. You're not going to submit any numbers to CMS. That's an automatic 4% penalty. The payment adjustments are effective 2019. So you're just going to be dinged with it right away. Test participation, which there will be a future presentation on that will go in depth on it, should be available before November 1st, will allow you to avoid the negative payment adjustment and possibly open up a minor bonus, but I highly doubt it, and you'll see that in that presentation. But that's the easiest way, submitting one quality measure or submitting just the base ACI measures or one improvement activity. 90-day participation, which is our recommendation, is full participation over at least 90 continuous days. So what full participation means is you do 6 quality measures, one of which has to be an outcome or high priority, the full ACI category, and the full improvement activity category. This, 1, avoids the negative payment because you're doing more than the test participation, and 2, opens you up for the maximum bonus available this year. 365-day participation, I also include that as not really a track. It's basically the same thing as the 90-day participation, except it's for the full year. You don't have the opportunity for any additional points because you did a longer period of time. The idea that CMS had is that if you have a full year worth of data, you may do better than if you only submitted 90 days. That logic doesn't make sense to me, so I pretend this particular track doesn't exist this year. You can also choose to report as a group or as an individual. So group reporting, basically all providers that have a single TIN will report as a single entity. The downsides or the caveats to this is that it has to be all or none. So if you're going to do group reporting, all providers that fall under that TIN have to be part of the group. You can't take one out, have them be individual, and the rest of the group be report as a group. In 2018, CMS is going to introduce virtual groups that's going to change the TIN requirement. So effectively, providers that do not all have the same TIN can make themselves a group and report that way. But there'll be more information coming out about that in 2018. The other thing to note about group reporting is your reporting track, measures, and periods are all locked in. So, you can't have one individual do a test track and the rest of the group do 90-day reporting. At the same time, the whole group has to attest to the same 6 quality measures. When we get into the scoring, it'll kind of make sense, but basically your numbers are aggregated, and the easiest way I can think about this is pretend your group is a single person, and all the numbers that apply to that group are rolled all together, aggregated, and they're reported as individual performance rates for each of the measures. This is a shared credit, shared risk choice, but its benefits outweigh the negatives, and you'll see that when we get to ACI especially, and how transition to care is handled. Individual reporting is your other option, where all the providers are basically on their own. There's more flexibility in measures, reporting period, and performance rates. So basically, one provider can do Q3, 2 providers can do Q4, right? They're all submitting their own numbers so that you're not locked into a single reporting period like you would be with a group. And they can also target different quality measures and things like that. So it's harder to manage, harder to track, but it's more dynamic. As far as payment adjustments, just like previous incentive programs, it's going to be 2 years later. So 2017 performance will impact 2019 payments, and then so on and so forth. The maximum payment adjustment for 2017 is plus minus 4%. Like I said, as long as you do at least the test track, you're guaranteed no negative payment this year. And you have the potential to get up to a 4% depending on how well you do in the program as a whole. Starting in next year, the payment adjustments are going to go up more, so it'll be plus minus 5 in the 2018 reporting period, 7 in 2019, 9 in 2020. It's expected to keep growing, but that's as far as they published. There is no test track in future years. So once we hit 2018, if you did test track before and you didn't set yourself up to prepare for 2018, you're open to getting that 5% penalty depending on how you perform in the 2018 reporting period. So as a scoring overview, and this is going to be illustrated as we move through each of the categories, where I kind of give some examples of how this would be calculated. But effectively, we're going to be reporting percentages. So meaningful use, it used to be, if you got over 50%, you passed that measure. It's not going to be that way anymore. Quality is going to be benchmarked against national averages. The quality benchmarks for 2017 are published and will be sent out as ancillary documentation to this presentation. One thing to note is that the quality benchmark is per measure, right? So a 93% performance rate in MedRec might only put you in the 7-point range, but a 93% performance rate in, a cardiology measure might put you into the 10, the maximum range, because it's based on how well the nation as a whole, everybody reporting that measure does. ACI is threshold based, so it's a little bit simpler, and that'll make sense when we get there. The big thing, like I noted, is no longer pass fail. How well you do determines your score. Improvement activities are basically a yes/no attestation, so you have to say that you're doing it for at least 90 continuous days, whatever activity it is you choose. You're most likely already doing some of these. Cost, like I said, is calculated by CMS and it's claims-based. One, it's not part of 2017 final score. It may not even be in 2018. And two, it's completely calculated by CMS, so there's not a lot you can do to prepare for it. There'll be more information coming out of CMS about this particular category in the coming months. So now we're going to go into the category-specific overview. This presentation is going to focus on full 90-day participation for simplicity's sake. If you want to do the year, just take everything that you're learning here and apply it to the whole year instead. And test track, like I said, there'll be another presentation specifically to that coming up by November 1st. Quality, which, like I said, replaced PQRS, basically, is 60% of your total MIPS score. So that this is the biggest piece. The big change from PQRS is that it's performance-based. Like I said, you're going to be benchmarked against your peers. So it's no longer kind of a pass-fail, just submit your numbers kind of thing. You have to select, and remember we're doing 90-day full participation in this presentation. You have to select at least 6 quality measures to report. You have to report on them for at least 90 consecutive days. You could do 120 days, 130 days. If you want, it has to be at least 90. They don't put a high cap on it. You must include at least one outcome or high priority measure. Outcome is the preferred measure to select. You'd only default to a high priority if no outcome measures applied to you or you were unable to report any of them. The maximum score you can get on a quality measure is 10 points. There's also bonus points available for the quality piece. And basically what it means is for each additional outcome type quality measure you report or each additional high priority measure you report, you get either 2 or 1 bonus points applied to your final quality score. Bonus points are capped at 6. So some measure selection logic that we have, and again, there's going to be a detailed presentation on the quality category, which will include recommendations on measures to select. It will be available by the second week in November, but this is just kind of an overview. So our recommendation is you'd want to target 8 measures or so to take a look at and to try to report for, quote unquote. And the reason for that is it'll allow you to pick your best 6 at the end of the year for reporting. When you're selecting your measures, you want to check a couple things. One, you want to make sure that they're related to your specialty. You don't necessarily have to report measures that are directly related to your specialty this year, but if you can, you should, and it'll help ensure that you're capturing the data that you're targeting. You also want to make sure that they're available to report in your reporting solution, whether it's the CQR or a registry. They're not all certified to do all of the measures. And you'll also want to make sure that you're picking measures that your documentation, your current form documentation, either can capture or does capture. All right, so don't pick a measure that you don't really document. Otherwise, you're not going to be able to report what you do. Some recommendations we have is to data mine any performance rates from PQRS last year if you did PQRS. Take a look at that compared to the benchmarks published by CMS, which, like I referenced, will be available as part of the supplemental documentation of this presentation. You can also take a look at your current CQR performance, or if you're part of a registry, your current performance in your registries. What you want to do is pick those where you fall into the highest decile, which is effectively your benchmark range. You can also target ones that the workflow incorporation would be easier, right? So a simple one, although everybody probably does it, is like MedRec. So CMS 130 is documentation of current meds in the medical record. If you don't do it, it's really as simple as kind of following the med reconciliation workflow. All right, so that's an easy one to target. So the scoring process is as follows. You have to have at least 20 cases for CMS to take your numbers. So that means 20 patients in your denominator. As a reminder, if you're going to do group, and how we want to think about groups is a group is just an individual, right? So even if you're a group, you still only have to hit 20 for your entire group in order to report it. You also need to have at least 1 in the numerator. Effectively, that 1 proves that you're capable of reporting that data. Meeting those 2 pieces gets you 3 points. As a reminder, the most you can get on a quality measure is 10 points. After you hit that basic level, your performance rate is going to determine where you are. So you may still be at 3 points if you're, at the lowest performing decile of all submitting users, or you may be higher up in the decile range if you're a high performer compared to your peers. So you're going to fall somewhere between 3 points and 10 points. And like we see here, if you're in the 8th decile, you get 8 points. So remember, you're going to fall somewhere between 3 and 10 if you can submit the data at all. Quality performance score, so your overall score for quality is going to be determined by kind of that simple math, right? So how many points did you get in all 6 of the quality measures you attested to? Add in any extra bonus points you might be getting from additional outcome or high priorities, divide that by 60. The one important thing to note here is that CMS is only going to score your highest 6 performing quality measures. So if you fit the denominator and numerator requirements for a 7th and 8th measure that are both outcome-based, your performance rate is really low, but you're able to report it. You could report those 2 as well and just get those 4 bonus points applied to your total score. It doesn't add anything to your denominator. They're only going to score your top 6 performers. You submit those other 2 so that so basically you get bonus points and they get to see additional data. And that's going to be covered in detail when we do the in detail quality presentation. Advancing care information is 25% of your final score. Like I said, this is effectively meaningful use. It's got different focus and it's scored much differently, but it's very, very similar. All of the measures are going to be familiar to you. The ACI category is comprised of 3 pieces, basically. The base score, which is worth 50 points. You either get it or you don't. Your performance score, which can net you up to 90 points, or your bonus score, and your bonus points, which is up to 15 additional points that you can get. The important thing to note here is you have to hit the base score to get any ACI points. If you do not get the base score, you get 0 points in ACI. So that's very important to note. Another thing to note is you may have noticed that 50 plus 90 plus 15 adds up to 155. You are capped at 100 points, so whether you submit 100 ACI points or 140, you still only get 100% of the category, aka 25 MIPS points. There are 2 tracks in 2017, the transition year tracks and the standard measures. Nobody's going to do the standard measures. I wouldn't suggest it to anybody. So we're going to focus on the transition year. The standard measures are just harder. So I don't know why anybody would pick them. So the base score, which as a reminder, you have to get any ACI points. You have to have a security risk assessment. You have to have at least 1 in your numerator for e-prescribing, at least 1 in the numerator for transition to care. So 1 successful transition to care, and at least 1 in the numerator for patient portal access. Hitting those 4 things gets you the 50 points associated to the base score. Missing any one of these 4 means you get no points in ACI. One thing to note, and this is where group reporting really shines, transition to care is generally a trouble spot. If you report as a group and one of your providers in that group has a successful transition to care, that counts for the whole group. Another thing to note is that CMS has stated they overlooked providers who do not refer or refer infrequently when designing the transition to care requirement. They said there might be some update to how they're going to handle that. Nothing's been published as of yet. I would not count on it. So transition to care is generally the trouble point, which is why I harped on it quite a bit there. Your performance piece of ACI is based on your rate achieved. So there are 7 measures that they're going to take performance rates on. In the transition year, provide patient portal access and sending transition to cares are double measures. So effectively, they're worth twice as many points as anybody else or any of the other 7. So what this really means is if you score somewhere between 0.01% and 9.99%, you get 1 point. 10 to 19.99, you get 2 points, et cetera, except in patient portal access and transitions of care, which you just double that. So if your performance rate, and we'll see this in a minute, in patient portal access is 20%, that equates to 4 points instead of 2 that would in any of the other 10-point measures. The other measures that are there for you, like I said, should be familiar for meaningful use, but they are patient view, download, transmit. So the patient viewing something on the patient portal, basically, providing patient education, sending secure messages. So this is providers or organizations sending out to patients, MedRec, and then participation in immunization registry. This totals up to your maximum possible performance points of 90. I don't think anybody in the world will hit 90 there, but you could if you are unbelievable at all of the measures. Another thing to note is there's no exclusions or exemptions, right? So if you are a specialty that does not do immunizations and therefore are not part of an immunization registry, you just don't have that option. There's no way to like get out of it. You basically just don't report it. Bonus scores for ACI, there are two. So one is participation in a clinical data registry other than the immunization registry. That gets you 5 points. It's just a yes, no. Some reporting registries themselves count. So if you're a cardiologist and you're part of Pinnacle, or an ophthalmologist and part of IRIS, those count. Other clinical data registries like cancer registries may count. What I would suggest is talking to an organization you may submit clinical data to and finding out if they qualify for this particular measure, or bonus point, I should say. That's worth 5 additional points in ACI. Submitting an improvement activity through the EMR gets you an additional 10-point bonus. So the CQR has certain improvement activities that they can do this for. Some registries, if you're choosing to report that way, also have the capability of doing that. What I would suggest is taking a look in either the CQR or your registry to see what's available to you. When we do the improvement activity detailed presentation, I'll list out the CQR improvement activities that apply. But if you look in the CQR and you go to improvement activities, it actually says whether it's an EMR reportable measure, and it's just in one of the columns that's present on the improvement activity screen in the CQR. So the total possible bonus points you can get is 15. Now to kind of bring that home, because it's pretty confusing, is a hypothetical example of a practice. So we're going to say that this practice hits all of the things they need to get their base score. We're going to pretend they're a group. So, 2 of their providers do transitions of care, 4 of them didn't, but they passed because they had at least one as a group. So now they have 50 points in ACI right now. A hypothetical performance score is here. So they have strong portal access, 72.32%. That correlates to 16 points. Remember, this is a double measure. Their performance rate on TOC is 41%, which correlates to 10 points. And you can see the rest of them here. The one important thing to note around transition of care is there's no low volume threshold. So as long as you're accurately capturing your denominators and your numerators, you could theoretically attest to a 7 of 10, right, for 70%, which equates to 16 points, right? And you get all of that, even though it feels weird that you only did 10 transitions of care, there's no low volume on it. So as long as you're confident and can back up in the event of an audit that you captured all 10 of the transitions of care, you really do, you don't have to worry about having those low volumes. For this hypothetical practice, for bonuses, I'm going to say they don't participate in any other clinical data registries, so they get 0 points there. But they do have an improvement activity that they can report through the CQR. And the hypothetical example we'll use here is 24/7 on-call coverage. When we do the improvement activity detailed presentation, I'll go through some of those measures. But it's really 24/7 on-call access is what it sounds like. You have 24/7 on-call, and that person who is on-call has access to the patient's clinical record. So we'll say we get 10 bonus points here for doing that. What we end up with is a score of 102. And remember, we're capped at 100. So we have 100% of the 25 ACI points available. Remember, the ACI category is 25% of the total MIPS category, the total MIPS program. The total MIPS program is out of 100 points, so 25% of 100 is 25. So what we end up with is the full credit from ACI applied to our MIPS score. After this section and the cost section, I'm going to kind of show you how we bring all the different category scores together into that final MIPS score. So improvement activities, like I said before, is new, and it's 15% of your final score. You have to get 40 points at least to get the full score here. So 40 improvement activity points. It's a little confusing, but effectively they have two weightings to all of the activities available to you. They're either high weight or medium weight. High weight activities equate to 20 points. Low or medium weight activities equate to 10. There is no low this year. It's opened up for future years. This is a strange caveat to that. If you're part of a practice with 15 or less MIPS eligible clinicians, regardless of whether that practice is attesting as a group or as an individual, the weighting of these two categories doubles. If you have more than 15, that's the pointage that you're going to be looking at. So effectively what that means is if you're a practice of 12 eligible clinicians, you only have to do one high weight activity to get the entire improvement activity category. If you're a practice of 17, you have to do 2 highs, a high and 2 mediums, or 4 mediums to get the full credit available to you. The one thing I like to note here is you're most likely doing enough of what is available right now today without realizing it to get full credit for this. What I suggest is taking a look at the qpp.cms.gov website that lists out all 93 of the activities that are available this year and seeing which ones that you may already do. And again, there's going to be a detailed presentation on improvement activities available by the 11th. So again, the attestation process is yes, no. So effectively, you say, yes, we have done this for at least 90 consecutive days. What you'll want is official policies written down or other supporting documentation, depending on what the activity is, in the event of an audit. Right? Kill them with paper. So you just want to make sure you cover yourself there, but it's not like meaningful use. It's not like, you know, former PQRS. You don't have reports to back it up. So you need policies and documentation. If you get to that 40 points, you get 100% of the category. And remember, the category is 15% of the final MIPS score. MIPS is out of 100 points, AKA 15 points towards your MIPS score here. You can get a percentage of that, right? So if you're a large practice and you only do one high level improvement activity, you're going to get half of the improvement activity available points, or 7.5 points applied to your final MIPS score. So it's not all or nothing. Cost, like I said, is 0% of your total score this year. Effectively, to keep yourself sane, you can kind of forget about it for now. It'll come back in early 2018. There'll be more information provided about it. Effectively, what it is, though, is a replacement to the value-based modifier. It's 100% calculated by CMS through claims. They keep saying that it might be weighted in 2018, and then after that saying that they're thinking about not weighting it anymore. So what I would do is stay tuned. There's a chance that this will be put off again one more year. So how total scoring works is as follows. The points you achieve in your quality category, plus the points you achieve in your ACI category, plus the points you achieve in your improvement activity is your total MIPS score. So here's an example. I just kind of made up based on clients that we work with. 35 is generally where people fall, unless they've been working at this for months. So that'll put you at 58% of the quality category. The easiest way to think about this, though, because it's scored out of a maximum of 60 points and quality is 60% of your MIPS total score, is just fully think about it in points. So 35 points would be applied to your MIPS final score based on this performance rate and quality. Then from the two examples we had done earlier, they had full advancing care information points, full improvement activities. So 35 plus 25 plus 15 is 75. That would be their MIPS score. The CMS is estimating that 70 plus points is going to put you into the bonus area. So anything less than 70, you probably won't get a payment adjustment at all. But anything for this year, and that's because of the test track, and very few providers are probably going to get any negatives. So it's hard to even it out. So anything over 70 points will put you into some sort of bonus payment area. And remember, minimum participation, so that's the test track, AKA getting at least 3 MIPS points, will avoid any negative payment this year. So you have some reporting options. Some of them are fully inclusive, some of them you can pick or choose, so you don't have to report with the same program for all three of the categories. Even if you're a group, right, that restriction where you have the same period, the same measures, that only applies to the category itself. So theoretically, you could submit quality through a registry and ACI and improvement activities through web-based attestation, which if you've done meaningful use in prior years is basically how you used to attest to meaningful use. You log into the website, you manually type your numbers in. But the CQR is the EHR reporting method, and that has the capability of reporting all three. So you can house it in one single place if you wanted to. Some registries, I've mentioned them prior, but Pinnacle and Iris, for example, have the capability of reporting all three. So you can manage it centrally if you need to. If that option is available to you, I suggest going that route. It's just a lot easier than trying to track numbers in a whole bunch of different places. There are other ways to report, but they're mostly available for large organizations of 100 plus providers, and they had required registration already, so you missed it this year. Like that's web survey based and other various methods. Based on what I've researched into them, they're a little bit more difficult, so there's a reason why they apply them to large organizations. They probably have the manpower to pull the reporting numbers a different way than you normally would. So the CQR is probably your best bet. Otherwise, if you're part of a registry, you could do that. Or like I said, you can do a hybrid. When it comes to report in 2017, and one thing I should have put on here, and I'll mention now, is that the attestation deadline is going to be the last day of March of 2018. So they're giving us an extra month compared to what they used to do for meaningful use. But here is kind of how to report in 2017. One, if you don't have the CQR or a registry, you can't submit your quality numbers. Technically, you can do claims-based, but you would have had to have been submitting specialty codes to CMS already. So unless you have been doing that, that's not going to be an option for you either. So you want to make sure the CQR is at least hooked up. ACI and improvement activities has an attestation option, which, like I referenced on the last slide, is effectively a website you go to and manually type your numbers in. CMS hasn't released the website yet. I expect that to be coming around the first of the year. One important thing to note here, and a lot of people ask about it, is you do not need to register as a group or as an individual prior to submission. You don't need to tell CMS you're going to be a group by December 1st, for example. The caveat here is that if you use a registry, they may have some internal mechanism where they require you to declare that early on. So just check with them to make sure that they're not going to force you to declare early. If they do, they probably have been emailing you constantly about it, so you would know. But the important thing here is, as far as CMS is concerned, how you submit your numbers tells them how you're submitting. So if you send them one set of numbers rolled up under a tin, they are assuming you're group reporting. If you send them individual numbers per NPI, they assume you're attesting as individuals. So it's not like you have to send in formal paperwork to CMS by X date. Some recommendations we have is, like I mentioned previously, CMS has stated they believe that 70-point threshold is where you're going to open up bonus payments. So that's a good target. If you're right around there, take a look at certain measures you might be able to improve. There could be mappings you could do on certain quality measures, or a tweak to a workflow that could drive up some numbers. So 70 is kind of what you want to target. Focuses should be higher performance in the quality category. You know, easier said than done, but really selecting accessible and attainable measures. Right, so taking a look at what you do capture, what your numbers look like now, before deciding that we want to do these 6 measures, and then finding out you don't collect data in a structured fashion for 3 of them. All right, so kind of putting the cart before the horse in this sense. Making sure you get that ACI base score. The biggest hurdle we see with most clients is transition of care. Right, so you need to get that to get any ACI points, and remember, ACI is 25% of your whole MIPS score. So you got to get there. As a opposite to that. Don't kill the staff chasing 1 or 2 ACI points, right? Don't drive them crazy trying to get patient education from 31% to 42%, because you're only going to get 1 additional ACI point. Remember, ACI is capped at 100 points. The ACI category is only worth 25% of your total MIPS score. So 1 additional point in ACI, if you're under the 100-point mark, only equates to 0.25 MIPS points. If you're going to drive people out of your office, it's not worth it for 0.25 points. The other thing to do is try to get 100% on improvement activities. I guarantee you already do enough to do that right now. You just want to make sure you go through them, select activities you do currently do, and make sure you have supporting documentation to defend it in the event of an audit. Some additional resources are here. This presentation is going to be published, so you can navigate to them from the presentation if you'd like. The main thing I want to note, and you'll notice something common here, they pretty much all start with qpp.cms.gov, and that's because they released this website in conjunction with MIPS around October of last year, and it's actually really, really good, way better than their previous documentation websites. So it's worth taking a look at. We'll also send out the benchmark Excel spreadsheet that they published earlier on in the year. They've taken it away from the provider/participant facing side of their education and resource page and hidden it under the registry page, but I nabbed it before they did that. So these still apply, and we'll send them out after this. That's the end of the presentation. So one thing I did want to go over is we had some common questions. So there are 3 questions that we get quite a bit that I wanted to address on this call. Then we will be sending out a frequently asked question type document. It'll be a living document through this presentation series. So it'll come out either in stages or at the end of all 5 sessions. The first question is, am I still responsible for submitting meaningful use and PQRS data? The answer is no, unless you are a pediatric practice or a practice that participates in the Medicaid incentive program from your state. If you used to submit the Medicaid incentive program to your state, you want to check with your state Medicaid program to find out if MIPS has supplanted it or not. So MIPS was the replacement for the Medicare program, obviously enacted at a federal level. Some states have decided that that's good enough for them. Some states have said, no, we want your Medicaid data, and that is old meaningful use stage 2, old PQRS. Most likely, you're not in a position where you have to do both, but it's still worth checking with your state if you ever used to do the Medicaid version of meaningful use or PQRS. So, well, not a great answer. That's as close as it can be without lying to you. What providers are responsible for submitting data through MIPS? So it'll be any MIPS eligible provider. And slide 5 of this presentation, which I'll see if I can get back to, will give you, where are you? There you are. The requirements. So basically, this is what you need to know if your provider is MIPS eligible. But really, the important thing here is go to this website, look up their NPI. Like I said, when I was on this slide, it'll also let you know what organizations, aka TINs, they're associated to as far as CMS is concerned, which means what groups could they be part of if you wanted to go group reporting. And the last question we get is, what is the penalty if our provider doesn't submit data in 2017? The penalty is a 4% negative payment adjustment on all Medicare payments effective 2019, so for that year. If you started submitting data in 2018, that 4% negative payment adjustment would apply only to your 2019 period. What your 2020 payment adjustment would be a reflection of how you attested in 2018. So that, I think that's a wrap. we kind of addressed all the questions that came through. If you have any others, please feel free to reach out, and we'll get them addressed in that frequently asked questions document that I made reference to. But thank you very much for your time, and I hope you have a good rest of the day.